Political leadership has to start bringing up the chronic disease agenda, the chronicity agenda, whether it's communicable diseases or non-communicable diseases. Most of them are chronic. And that's why we talk about chronicity. Now, one has to bring up that concept, or that idea, that narrative up to the policy level and turn it into a health policy. By doing that, one starts reinforcing the drive and the levers that one has to push into the system to make it change. Because otherwise the system right now is just basically comfortable in its status quo, whether we're in Switzerland, the Basque region, or in Nairobi. Everywhere the system is more or less comfortable, doctors here and patients here, primary care, a bit of primary care, a bit of hospitals. But unless you bring this agenda up to the policy level and introduce and force some of the changes, the delivery system that we have, which is broken up in fragmented pieces, is not going to come together. And if it doesn't come together, we're not going to be able to manage chronic diseases in the correct way. The population here in Switzerland or in Spain or in Belgium or in Africa and Asia is not stratified. Meaning by stratified is that you do not have the most vulnerable people at the top of the pyramid, less vulnerable in the middle, and least vulnerable at the bottom. So unless you actually do and you organize your population, that you can't target your intervention. And that is a very practical management tool to actually know who you have to address with what intervention, when, and how. If you do not do that stratification, if you do not apply that management tool, you're not going to be able to target your population. If you can't target, you're wasting resources. You have to start seeing patients not as people who you spend money on, but as a resource. So people actually are a resource. A person with diabetes, with AIDS, with arthritis, with hypertension, it doesn't matter. That person has to be seen as a resource, has to be empowered. So there are many ways of empowering patients through patient education, which allows us to start seeing that patients which are better engaged, which have been empowered, which have been educated, handle much better their diseases than when we expect them to be passive patients and dependent on the system. So those are two. One is a management tool, the other one's a line of work around patient empowerment. Both very powerful lines of work. And I think that is probably the most, the two main levers that we are specifically pulling through. And little by little, I think we start seeing results, positive results of getting doctors coming down from their pedestal and patients up from their knees, so that, you know, those two worlds, the medical and the patient, the nursing and the patient, start meeting in the right plane of conversation, so you have actually a dialogue instead of monologues going on. What is it that you have to bring together in information systems between primary care and hospitals so that those two worlds are talking to each other? So there are many levers that have to be pulled, but the first thing you have to do is make sure that it comes up to the policy level, design your interventions as much as possible with the local people. And once you've done that, you know, that has to be your main priority and your main policy drive. Some countries have less money than others, but the challenge is the same. One has to then modulate the level of intervention so that it fits the level of resources you have. But the important thing is that some of the answers both types of countries are identifying are both useful for both. So they're both, it's extremely important to continue having a forum like the present one, which brings together those two worlds and says, how can we move forward together?